All right. Hello, everybody. We're going to start our CEU on integrating acceptance and commitment therapy and cognitive behavior therapy in ABA, which is the title of our presentation today. This is going to be online, synchronous and asynchronous. The current date is March 4th, 2025. We're going to go approximately from 9 a.m. to possibly 11:15 a.m., depending on discussion. This is going to be worth 2.5 general CEUs. We already went through our roll call. Attendance will also be taken. There's going to be a small test that will be emailed, as well as a short survey afterwards. That is how we will take attendance. And once those are completed, we will be able to get certificates out. If anybody is viewing this asynchronously, just go ahead and send me an email, and then I'll get those to you. And on our own time, we can get those back for credits. This is free, obviously, unless you guys want tips. I always accept tips. Uh, this is designed for BCBAs. I would say it's more advanced level. Some of our learning objectives, we're going to summarize cognitive behavior therapy. We're going to summarize acceptance and commitment therapy. We're going to analyze the applications of both models within ABA. We're going to identify ethical considerations, and we're going to conceptualize treatment targets and materials. There are a few links that will be given out for access to materials that you guys can use during your treatment planning. In the task list, I identified a few of the specific topics that we will be going over today. Define and provide examples of unconditioned, conditioned, and generalized reinforcers and punishers. We're going to define and provide examples of derived stimulus relations. We're going to talk about reviewing records and available data, using self-management strategies, and we're going to talk about intervention goals in observable and measurable terms. All of these things we're going to apply to these models that we will talk about today. So we're going to start off first with cognitive behavior therapy. ACT actually builds upon cognitive behavior therapy, so it's a nice segue that we go into when we talk about both of them. So, a little bit of background on cognitive behavior therapy. In the 1960s, Aaron Beck developed cognitive behavior therapy, or cognitive therapy. Since then, it's been extensively researched and found to be effective in a large number of outcome studies for some psychiatric disorders, including depression, anxiety disorders, eating disorders, substance abuse, and personality disorders. It's also been demonstrated to be effective as an adjunctive treatment to medication for serious mental disorders such as bipolar disorder and schizophrenia. CBT has been applied and studied for children, adolescents, couples, and families. Its efficacy also has been established in the treatment of non-psychiatric disorders, such as irritable bowel syndrome, chronic fatigue syndrome, fibromyalgia, insomnia, migraines, and other chronic pain conditions. Of course, for our purposes, we're going to focus on more of those cognitive disorders. So the idea for developing this form of psychotherapy took root when Aaron Beck began to notice that his patients with depression often verbalized thoughts that were lacking in validity, and noticed what he called characteristic cognitive distortions in their thinking. His empirical observations led him to start viewing depression not so much as a mood disorder, but as a cognitive disorder. Based on his clinical observations and empirical findings, Beck outlined a new cognitive theory of depression. He published Cognitive Therapy for Depression in 1979 after having published a study that evaluated and demonstrated the efficacy of cognitive therapy. The combination of detailed treatment protocol manual with outcome research was innovative in psychotherapy practice that had that had only previously been attempted by behavior therapists in discrete behavioral problems. By accomplishing the same feat with a more complex set of clinical interventions that included cognitive, emotional, and behavioral components, Beck pioneered a model for psychologists many years later, and he defined it as empirically validated psychological treatment. Other clinicians and researchers, they became interested in developing the CBT treatment protocols and evaluating the efficacy. Specific treatment protocols were developed for some psychiatric disorders. As behavioral strategies were incorporated, this is where our ABA comes into play in the early stages of this, the term cognitive therapy changed to cognitive behavior therapy. Today, CBT is one of the most extensively researched of all psychotherapies with several evidence-based treatment protocols. So we're going to focus mainly on the behavioral component of this, knowing that we're also going to touch base on some of those internal thought processes. So the cognitive model, CBT is based on straightforward, common sense model of the relationships between cognition, emotion, and behavior. So the three aspects are emphasized: automatic thoughts, cognitive distortions, and underlying beliefs or schemas. We're going to go into more detail about each of those. So automatic thoughts are an individual's immediate, predetermined interpretations of events that are referred to as automatic thoughts. So the first thing that comes into somebody's mind. Automatic thoughts shape both individuals' emotions and their actions in response to events. For example, a friend might cross you in the hallway and not say hello to you. Your first thought, the automatic one that just pops into your head, might be, he hates me, or I've done something to make him mad. And this is likely to impact your mood and cause you to feel upset and also to behave in an avoidant manner when you see him the next time. On the other hand, if you had the automatic thoughts, he's in a hurry, not a big deal, you would not be as concerned and you would not be avoidant when you see him the next time. So CBT is based on the observation that dysfunctional automatic thoughts are exaggerated, distorted, mistaken, or unrealistic in other ways. And this plays a role in psychopathology. So not everybody's going to have those automatic negative thoughts, and sometimes they might self-correct them. But when the individual does have those really negative thoughts that change their behaviors, that's when we come up with individuals that might have really avoidant negative behaviors when interacting with their environment. And so that's our role as behavior analysts, to focus on the behaviors while also understanding that those behaviors came to surface from some of those negative thoughts that might be arising internally. So some cognitive distortions could be I can't even pronounce this one. There are things are seen as regarding two mutually exclusive categories with no shades of gray in between. So those people that think in black and white, I'm either good or I'm bad. Overgeneralization is another cognitive distortion. So taking isolated cases and using them to make wide generalizations. So I bumped into this person and he called me an idiot. So anytime I make mistakes, I'm an idiot. You know, that was just one isolated case, one situation, but somebody who might have these cognitive distortions, they might overgeneralize that and think that anytime they make a mistake, they're an idiot. Selective abstraction, so focusing exclusively on certain, usually negative or upsetting aspects of something while ignoring the rest. So we're in a basketball game and I stubbed my finger and then I missed the pass and someone stole the ball. If someone has cognitive distortions, they're going to focus only on that. They're going to forget all the three-pointers that they made, all the passes, all the good things that they did in that game. Disqualifying the positive. So positive experiences that conflict with the individual's negative views are discounted. So sometimes even when we have situations that are contrary to something that was negative happens. So let's say going back to the situation where we bumped into someone and they called us an idiot. Maybe another time we bump into someone and they are super kind. They say, "Oh, I'm sorry, I was in your way. No problem. It's cool. Hey, I like your hair." So disqualifying the positive that person, even though they are experiencing the positive situation, they're going to ignore that and they're going to think back to the time that the guy called them an idiot. Mind reading is assuming the thoughts and intentions of others. So everybody around me in the grocery store thinks I'm an idiot. They didn't see anything that happened, but now everybody looks at me and they must be thinking I'm an idiot. All of these cognitive distortions can lead people to these negative thoughts that are going to result in them having maybe avoidant or negative behaviors. So a few more: fortune telling, predicting how things will turn out before they happen; minimization, they are going to treat the positive characteristics or experiences as real but insignificant. So, oh, that person, they didn't really mean that it was okay that I bumped into them. Um, that wasn't significant at all. Catastrophizing, focusing on the worst possible outcome, even though it's unlikely, or thinking that a situation is unbearable or impossible or just uncomfortable. So if I go to this party, I'm probably going to spill punch everywhere and it's going to get on the birthday girl, and all my friends are going to take pictures of me, and then somehow a fire is going to start and the house is going to burn down. That is the biggest catastrophe that could happen. They're focusing on that, so they're not going to go. Their behavior is to not go to that party. Emotional reasoning, so making decisions and arguments based on how you feel rather than the objective reality. So I I'm mad at my partner because they didn't offer to do the dishes. And so they're focusing on that emotion, and their behavior is going to be yelling at their partner or maybe their parent because they didn't help out, when there's probably a whole lot more that go to that situation, but they're focusing on just the pure emotion. That is that automatic thought that arises. Should statements. So concentrating on what you think should or ought to be rather than actual situation you're faced with, and you have rigid rules which should only apply no matter what. So for example, my parents should always respect me when I'm tired. They should always let me rest when I'm tired. This is how that's how it should be. That cognitive distortion as an automatic thought can lead to problem behaviors when, let's say, your kiddo is a little bit tired waking up and the parent says, "Hey, guess what? We got to go to school anyway." And so that automatic thought of my parent should let me sleep in when I'm tired can lead to behaviors that are screaming, cursing at them, throwing things, destroying their room, and refusing to go to school. Personalization, blame, or attribution. So assuming that you are completely um, or directly, sorry, this one I can't see. Oops, my notes. uh, so you're not responsible for a negative action when applied to others consistently. So it's not my fault that I threw something at my mom's head because she's the one that woke me up. She's the one that wouldn't let me sleep. So not taking accountability for actions that can also kind of build upon those should statements or other cognitive distortions that will lead into someone's behaviors. So these are a lot of very specific examples, and these are all things that happen internally within somebody, but we don't want to ignore those because those can be driving factors behind their behavior. So as behavior analysts, we look at changing the environment and the response to the individual to change the behavior, but we also don't want to ignore that these internal processes are also affecting behavior. So some of the underlying beliefs, talking specifically, Underlying beliefs shape the perception and interpretation of the events. So belief systems or schemas take shape as we go through our life. They're defined as templates or rules for information processing that underline the most significant layer of automatic thoughts. So beliefs are understood at two levels in CBT. Core beliefs, these are central ideas about the self and the world. They're the most fundamental level of belief. They're global, rigid, and overgeneralized. So some examples might be, I'm a loser and the world is an unfair place. That's going to define how we interact with the world. So some more examples, I'm unlovable, I'm inadequate, the world is a hostile and dangerous place. So very similar. And then intermediate beliefs. So these are assumptions, attitude, and rules. They're influenced in their development by our core beliefs. So some examples, to be accepted, I should always please others. I should be excellent at everything I do, to be considered adequate. And it's best to have as little as possible to do with people. So those are some things that might come from our core beliefs, but these are just some assumptions that come from that. Okay, so that's just a basic overview of CBT. We're going to talk about how that's developed into acceptance and commitment therapy. After we go through the process of acceptance and commitment therapy, then we're going to look at how both of these complementary but different models can be integrated into ABA. So acceptance and commitment therapy, I'll say personally, it's one of my favorites. Not only do I feel like it really gets to some of those internal processes that can be driving behaviors, but it just feels fun to talk about values. All right. So going back into some history. So acceptance and commitment therapy, it was part of the third wave of cognitive behavioral therapy, CBT. So we're going to go a little bit more deeper into that history. So the first wave was traditional behavior therapy, focuses on observable behavior and direct interaction with the environment. So our good buddies Pavlov, Watson, Thorndike, and Skinner. Those are the well-known people from this era. They really built the framework for applied behavior analysis as well. So exposure work and skills training are the main interventions within the clearly defined empirical framework. Such interventions worked, but they're unable to account for the problems of thinking and influence of private events on behaviors. So in response to this, cognitive theories began to emerge over the past 30 years and have taken really a focus in these therapies. So this started the second wave. Researchers Beck and Ellis, they were the key figures, and illogical thinking or thinking errors are seen as the problem cause of any problem behavior. So the evidence base for standard CBT is extensive. They emphasize on outcome research and randomized control trials across a wide range of disorders. So these worked, but they're unable to account for the problems of thinking and influence of private event on behaviors. So in response to this, sorry, next slide. So in the second wave, they started thinking about thoughts, but the scientific link between the process of cognitive change and outcomes was not quite established. So this set the stage for emergence of new treatment models that focused on the function of problematic conditions rather than the content. So this third wave of CBT differs from the first wave in that it has considerable focus on private events, and it differs from the second wave in the fact that it doesn't try to change the form or frequency of private events. So cognitive behavior therapy is going to be more focused on changing our thoughts. For example, how can we think more realistically about bumping into somebody and what they say to you? Or, you thought that your friend hates you because they didn't say hi to you in the hallway. Let's change that thought. So this third wave is not so interested in changing those thoughts to more positive ones. So these new treatments developed to expand on the evidence base of these CBT. So based on acceptance and mindfulness procedures, the third wave of CBT includes stuff like dialectical behavior therapy and acceptance and commitment therapy. We are going to focus on acceptance and commitment therapy. So a big piece of the foundation of ACT is relational frame theory. We've learned this in our studies as behavior analysts, and so this fits really nicely into the field of ABA. It's a basis for our work. It's a basis for ACT. So those two things can mesh together really nicely. So we're going to go over some basics of relational frame theory. This is really, really extensive stuff. So I definitely would encourage everybody to look more deeply into this if you haven't had refreshers. But we're going to go through the basics as it pertains to ACT so that we can connect it to ABA. So it's been developed for the past 25 years. It's a post-Skinnerian model providing empirically based account of language and cognition. It is the basis for acceptance and commitment therapy. So it emerges from earlier work on rule, governance, and derived stimulus relations in the behavior analytic tradition. Relational frame theory extends these ideas in regard thinking itself as a special form of learned behavior in its own particular class. So from the RFT perspective, language is seen as the main difference between humans and non-humans, and relational framing as the core process in developing language. In a developmental continuum, more complex language abilities develop over time, and relational frames continue to expand throughout the lifespan of an individual. So a derived stimulus relation is a relation between two or more stimuli that are not directly trained or taught and is not based solely on the physical properties of the stimuli. So physical properties just means the way a stimulus looks, sounds, feels, or tastes. A derived stimulus relation is a relation between two or more stimuli. Oh, sorry. I'm reading that one over again. So for example, we can specifically teach somebody that the written word FOX on a piece of paper is connected to the auditory of someone saying fox. We can also teach an individual that the written word FOX on a piece of paper pertains to the image that we see here, which is a fox. So those are the taught relations, and derived stimulus relation within relational frame theory states that the learner is going to derive the relationship between the verbal auditory fox and the picture. We didn't specifically teach them that. Those connections are derived. So that's just a very basic example of derived stimulus relations. We use this all of the time in ABA. So our DTT work might be teaching kiddo to have the written word fox on a flashcard, and they're going to match it to pictures. They might have a picture, one is of a fox, a dog, or probably we'll use unsimilar items, a fox, a bird, and a fish. And we teach them to match those things. So we're teaching them specifically that. And we might teach them that to read the word fox, and that they're going to say fox, and that's connected to the written word FOX. And they are likely just going to pick up after learning both of those things that saying fox is the same as the image of fox. So relational frame theory, this is something that we use to teach our kids, like the example I just talked about, but it's also used in basic problem solving. So we're going to do just the following thought exercise. Imagine that there's a screw stuck in the wall and you need to remove it. The only tool that I give you is a toothbrush. With just that tool, you're probably not going to easily find a solution. However, if I add a tool and I give you a cigarette lighter, then a solution might become more apparent. Relational frame theory attempts to offer an explanation of how human beings can solve problems like this in the absence of actual objects. So, you know, you might already have learned previously that a toothbrush is plastic, at least by examining the one that I gave you. And you might have already learned that plastic can be melted. Looking at your lighter, you've already learned that a lighter creates heat. You're going to derive the connection that, well, if plastic can be melted and this lighter can cause heat and heat makes things melt, I can heat the lighter or heat the toothbrush with the lighter. And then you might have already learned that when things are melted, they're more pliable, they can be manipulated, and you can change them. So then you might derive the relation that if I melt the toothbrush, I can make it pliable. And then you might have already learned that pliable means you can reshape things. And then when they're hardened or when they are cooled, they're hardened. So then that can lead you to the derived relation that if I heat this, press it into the screw, it's going to harden. It's going to cool, harden, and then I can turn it. So that's a pretty interesting example of how relational frame can lead us to solve complex problems. So it's RFT, relational frame theory, in this way has allowed humans to become successful problem solvers. And this really separates us as the dominant species. Other animals have been seen to use that, but definitely not in the extent that humans have been able to use this. And there's definitely a darker side to that. So our ability to problem solve through derived relations can also be the process that underpins mental health disorders. So Prince, a car crash, and pizza. Do you follow? No, it makes no sense. All right, let's make it make sense. So let's say you are in a car and Purple Rain by Prince is playing on the radio. And then suddenly you get into a really bad car crash. You take a while to heal up. You still have a lot of trauma from that car crash, but you're on the mend to healing. And let's say you go into a pizza place and you have some pizza with your friends. And Purple Rain comes on the radio. You may make the connection of thinking back to, oh, this song was playing on the radio when I got into my horrible car crash, and that might bring up memories of the car crash. And then you might feel sad, you might feel scared, you might feel anxious. You might not even remember at all that Purple Rain was playing on the radio, but by the mental process that happened with relational frame theory, you've learned those derived relations. So you derive the relation between Purple Rain and the car crash, which causes these anxiety thoughts leading back to your trauma. These derived relations might further make connections. So maybe later on, Purple Rain's not playing at all anymore, but you see a pizza again. You might start to feel anxious, sad, depressed, and the car crash isn't even present. Purple Rain isn't even present, but those things have been connected to pizza. Maybe that further generalizes to all restaurants. Maybe you find yourself not being able to go to any restaurant at this point because you are having feelings of anxiety, and then you start to exhibit avoidant behaviors of not wanting to go out, and maybe over time you're not even leaving your house. So that's an example of how these derived relations can kind of go awry, and these can lead into formations of mental health disorders. Okay. So from a clinical perspective, relational frame theory shows how humans are able to interact with events purely on the basis of verbally ascribed functions, while being completely unaware of the underlying process of language. So, like I said, we don't have to be completely aware of our connection between the song and the car crash. These are just ingrained into us. In the world of thought, the event and the person thinking about the event are usually experienced as one, so it appears real. Words alone can elicit pain. So in ACT clinical work, undermine the functions contained in language play a central role. That's what it's going to be focused on, as opposed to changing the content of thoughts. So looking back into CBT, we're not going to be changing the thoughts into more positive ones. We're going to be just undermining the functions. So a couple things are at play from an ACT perspective. Cognitive fusion describes the tendency to act in the world on the basis of verbally ascribed functions as referred to as cognitive fusion. So the thought and the person thinking the thought become as one or fused, hiding the nature of the language process. Fusion can lead to a loss of contact with actual events or real experiences, so that thoughts start to become self-confirming. So after our traumatic event of getting into a car crash, we feel this anxiety from these derived relations, and we start to be fused to the thought of I'm not safe anywhere that I go. Another example would be someone who encounters a disappointment, such as not getting the raise that they worked hard for. They might think that they're worthless. So that might be an automatic thought that comes in. And that might lead to them likely doing less because they feel worthless. Doing less sets up a cycle where there's reduced contact with actual events that further a feeling of worthlessness. So I didn't get my raise. I must be worthless. I'm not gonna try again. And then you're not going to try to do better to earn that raise or a new position or a new job because you think you're worthless, and therefore you're going to feel even more worthless. Fusion with the thought is strengthened, and a pattern is established that can develop into a mental disorder over time. So you might not always be able to shake those thoughts. It could turn into anxiety and depression, and then everything you look at can kind of be from that viewpoint. So from an ACT point of view, the increasing dominance of cognitive fusion is one aspect of the way in which psychopathology develops and produces a restricted repertoire. The other is more behavioral and emanates from the process by which verbally ascribed functions easily lead to negative emotions. For instance, worry can develop when thinking about the imagined future, and sadness or guilt can result from remembering the past. Mainly, these are normal experiences. Most people develop strategies to cope. Experiential avoidance is another thing that ACT looks to target. So the situation becomes problematic when individuals try and suppress or avoid the pain that is evoked through thinking. This is known as experiential avoidance, and has been defined as the attempt to escape or avoid the form, frequency, or situational sensitivity of private events, even when the attempt to do so causes psychological harm. So, for example, you feel anxiety when going out to restaurants, even though going out to restaurants increases your connection with other people, which creates positive situations, good memories, good feelings. Those friends are going to help you through things. They're going to say nice things to you. So you're going to be anticipating feeling uncomfortable going out to that restaurant. So experiential avoidance says that you're going to avoid it altogether, but then that cuts off your opportunity to engage in some of those reinforcing things in that situation. This might, is something that some of our clients can go through as well. Overall, they might enjoy coming to therapy or having the therapist come to them, but maybe they're anticipating the struggle because we are pushing them. We're asking them to do things that are difficult for them and sometimes uncomfortable. If they might get so focused on those uncomfortable events that they're going to engage in behaviors to avoid going to therapy at all. They're going to tell their parent they're sick, that they don't want to go. They might throw a fit. And then the parents, they might be dealing with their own relational frames of thinking about how difficult this kid is going to be on the way to therapy. And then I want to avoid that. And then everybody ends up avoiding the negative feelings. And in turn, that is going to cut them off from the reinforcing value. So that kiddo not coming to therapy, they are going to be cut off from all the skills that they can learn. Maybe they have a friend at therapy that they really enjoy playing with. They're not going to be able to access that. And so that's one of the real life applications that we want to be aware of that could be happening internally. So the same paradox tends to be emergent in most mental health disorders. So you try to get rid of unwanted private events, and this leads to actual increased domination by these events. The behavioral impact is increasingly restrictive repertoire over time can develop into a mental health disorder. So if you're focused on those undesired private events and that actually trying to avoid them actually gives them kind of more power, and you become kind of entrenched in those emotional thoughts. So the therapeutic aim of ACT is to deal with the fusion and the experimental avoidance. So cognitive fusion and experimental avoidance tend to create behavioral repertoires that are insensitive to the events in the moment, and they're inflexible in changing circumstances. The fundamental objectives of ACT are to undermine these processes and help clients move forward in valued directions by developing behavior that is sensitive to the current context. This is known as psychological flexibility and an increased ability to adapt. And these are the main focuses of ACT. So this is the diagram. They call it the hexaflex. This is present in my clinic in Florence. They have a lot of visuals for this. This is kind of a good way of understanding the 6 core principles of ACT. So the first is acceptance. It means taking a position of non-judgmental awareness towards the thoughts, feelings, and bodily sensations that arise in these situations. The process begins with the client learning to notice behaviors that are not moving towards values, known as ACT as unworkable. So ACT is really focused on identifying values and whether we identify with that individual what their specific values are and moving towards or away from them. After that, the client moves on to noticing how attempts to control unwanted private experiences leads to a struggle. So all of the things that they do to, let's say, avoid the negative feelings that they have during therapy, and they continue to struggle, and then they continue to avoid other things, and then they get entrenched in these negative behaviors that could have been helped by going into the environment and accepting those negative feelings to be able to move towards their values. So acceptance involves letting go of the struggle while still working on external issues that can be changed. Diffusion. Cognitive diffusion addresses the problem of the cognitive fusion that we described previously. It's about trying to dilute the impact of harmful functions contained in language. Sorry, one moment. I have to plug this laptop in. Sorry. While I'm doing that, does anybody have any questions so far on anything that we've gone over to this point? Okay. All right, we'll keep going then. All right, so diffusion. It's about trying to dilute the impact of harmful functions contained in a language. It involves trying to shift focus from the content of thought to the process of thinking itself, thus weakening the verbally ascribed functions. So diffusion creates distance from the thoughts as if the individual were standing back from their mind, like an observer. So in that fusion we talked about earlier, where a person might be fused with the thought of, I am worthless. They become fused with the thought as if that is true and that's a fact. In diffusion, there might be some exercises to help that individual become unstuck from that. So one example might be, you are a person observing you from outside of yourself, and you see the thought worthless. What are, in the context, like how can you say that's a fact? What are some things around you that might be contrary to that fact if you were looking at somebody else who was saying that? There's many more exercises that focus on that we can get into when we look at some of our examples. So contact with the present moment. Clients are taught to notice their external and internal experience in the present moment. The practice of mindfulness provides this foundation. So mindfulness is one of the really key practices when we're engaging in ACT. Later, this can be extended into operant exposure routines, in which a client learn to develop new behaviors based on the values that they choose in the presence of previously avoided experience. So in this way, contact with the present moment using mindfulness can be taught as a coping strategy. So this can turn into observable and measurable behaviors. So an individual is faced with a situation where they have to make a choice between, let's say, going to therapy or not going to therapy. And they're so entrenched, they're so fused with the thought that I'm going to be miserable with therapy, because maybe they're thinking about how uncomfortable they were when their therapist made them say hi to a peer. And they're not living in the moment, they're focused on that negative thought. Maybe their caregiver can help them be in contact with the present moment, or maybe we've previously taught them to be in contact with the present moment through mindfulness as a coping strategy. So maybe they might take a few deep breaths and they might notice their breath. They might notice their chest go up and down, and they're going to learn to allow those thoughts to be present. They're not going to try and change the thoughts, but they're going to be in the moment. And that's going to kind of help them diffuse from that thought and then be able to refocus on their values. Maybe their value one of their values that they've chosen is moving forward and being a progressive person. And so by having that moment of mindfulness to be more in contact with the present moment, they could stop thinking about that ruminating thought of how uncomfortable it is when their therapist makes them say hi to a peer when they would rather not do that. And maybe they're able to refocus on that value, and they can make the behavioral change to, instead of engaging the behaviors to refuse to go to therapy, instead they're going to be flexible and they're going to engage in behaviors such as getting ready, get in the car, and cooperating with parent to take them to therapy. Self as context. So cognitive fusion with thoughts such as I'm worthless is referred to self as context. The person's identity is caught up in the context of the particular thought. Acceptance and commitment therapy assumes, in order to fully experience painful feelings, or really stand back from the difficult thoughts without trying to change them, a wider perspective is necessary. This transcendent sense of self is referred to as self as context and can be developed through diffusion and mindfulness. So from this perspective, the observer self is not threatened by the context of experience, but is instead the context in which all experience unfolds. So once again, that kind of goes into the cognitive fusion, yourself as the context. So yeah. Then values. Clients are encouraged to clarify their valued directions or actions. So as we talked about previously, through mindfulness and diffusion, they can defuse from these thoughts, self as context, and they can learn to move towards their values. So these aren't feelings or goals. So happy is not really of value, and getting a job is not really a value. Those are feelings and goals, but we're going to connect to a deeper sense of purpose and meaning as an ongoing process of behavior. So while getting a better job and feeling happy are not values, being flexible could be a value, or being forward moving can be a value. That's going to change their ongoing behavior. So this component closely resembles modern existential ideas where choice and freedom of action are the main focus. Consequently, in ACT, the individual focuses on the future as opposed to exploring the past, and their chosen values underpin all aspects of the therapy. So while focusing on the past might lead to them thinking about the past struggles during therapy, focusing on the future is going to lead to more positive behaviors. And then committed action. It's about learning to move in valued directions while in the presence of unwanted or painful thoughts and feelings. So all of these things, the reason why it's in a hexaflex is because they all kind of connect to each other. Sometimes they might sound a little repetitive, but it's because they kind of all play off of each other in this hexaflex. You see that one line goes to the other, it goes to another one, and they're all connected. So the choice between an easy life and a rich, full life is presented, and clients are encouraged to find the willingness to have painful thoughts and feelings in the service of moving in a valued direction. Vitality develops as the client's behavior becomes more oriented towards underlying values. All right, so once again, this is a very, very complex method. CBT and ACT, they do have some overlap, and as well as in ABA, but these, once again, they're very complex. Each one can be several hours of CEUs on their own. So either the CEU might be an introduction for you guys if you haven't done any continued learning in these subjects, or you might already know it and these are just like a refresher, but we're going to focus on how to integrate these into acceptance or into ABA. So if you're not as knowledgeable about these basics, I would definitely encourage you guys to look more into it. And we're going to go over some articles that could possibly develop into other CEUs. So we could possibly take those and do some article views with those. So we're gonna move forward into how these can be applied in ABA. So whenever we're looking in our practice to integrate other therapies, we always need to be focused on the 7 dimensions of ABA. We need to stay true to our field. We need to stay within our scope of practice. So just to overview some of these. Applied, it involves using socially significant techniques to improve the learner's life. The behaviors vary based on the learner, so goals and interventions must apply specifically to that learner. Behavioral, the behaviors addressed in a treatment plan must be measurable and observable. It must involve things that translate into data to show the learner's progress. The data also helps determine further intervention plans that help that learner. Analytic. Every intervention used in the 7 dimensions stems from scientific research with analyzable results. Experts use evidence-based research, data, and objective information to determine goals and targeted behaviors. It allows for making educated choices about implementing specific interventions and setting goals. When professionals analyze the data from ABA patients, they look for connections between environmental and behavioral changes. When implementing new techniques, professionals document what happens to see if it helps decrease the challenging behaviors. Technological. Intervention plans include procedures detailed in technological terms because they're evidence-based and replicated. The procedure will be clear and concise so interventionists can understand and implement the plan. It's technical when it can only be interpreted one way. This way, multiple interventionists can carry out the plan without switching things up on the learner. Conceptually systematic. This dimension highlights that all interventionists use research-based techniques. They'll use the Journal of Applied Behavior Analysis and other trusted sources as sources for their teaching methods. Indicates that all interventions relate to the core principles. It is effective. Intervention techniques should be effective, meaning they improve behavior in a functional method. If the challenging behavior does not reduce, the intervention is ineffective. The interventionist reevaluates their technique to find an effective method for the learner. Analytic data can help determine when an intervention is effective or ineffective. Effectiveness often depends on the importance to the learner and those in their life. Interventionists must learn what's most important to the learner, often based in their culture and community. The importance can also depend on their age and what's socially significant for their age group. And then adapt to generality. When a behavior is sustainable over time, it's considered adept to generality. It means the learner can implement the behavior in various environments and settings, allow them to behave appropriately in different situations. Generality ensures the target behaviors last long-term, well after the intervention ends. The learner should be able to reduce challenging behaviors outside of a clinical setting, helping them at home, school, work, or anywhere else. Generality also ensures the learner can use different methods on behaviors that weren't directly targeted during the intervention. In ABA treatment, we learn to generalize differently. 2 techniques commonly implemented using different stimuli to teach skills and teach them in various settings. So just that overview of the dimensions of applied behavior analysis, we're going to make sure to keep those in mind when we are talking about using CBT and ACT in ABA. We can find connections to each one of those 7 core principles we're looking at. So while ABA has shown to be really effective, it's not without its criticisms. So some might argue that our focus on external behaviors can sometimes overlook internal experiences and emotions. Some might say it's like trying to understand a person by only looking at their actions without considering their thoughts and feelings. So in our field, we're starting to see more of an integration into realizing that these thoughts and feelings do play a factor in their behavior. So we want to be able to learn those things as well. But ABA is also adaptable. So we're going to kind of use those benefits to kind of make up for some of our shortcomings in ABA. And ACT, CBT, and ABA, they're all distinct. But since ABA is versatile, we can borrow some of these with some of these techniques. And it's going to broaden our scope to be able to help our clients, especially those with comorbid disorders such as depression and anxiety. Those are really, really common in autism, and those have shown to be less effective with just straight traditional ABA. So integrating these things, we might want to make these considerations when we're doing our initial assessments and reviewing relevant medical history of our clients to see if they do also suffer from anxiety and depression, then integrating acceptance and commitment therapy or cognitive behavior therapy, we might consider that effective to be able to help that learner. When we're doing this, we want to make sure we're still operating within our scope of practice. So, for example, when we're integrating CBT and ACT, we want to take CEUs like the one that we're doing and some more specific ones that that I suggested. There's a bunch out there, especially in ACT. And then relational frame theory is, like I said before, is so complex that one is always good to brush up on as well. And then we want to make sure that whatever goals that we create through the integration of CBT and ACT, that they're observable and measurable. So we will go into some examples on how to do that. So I tried this out earlier, but the link that I click on is not going to open up automatically. So if everybody can click on that link and just go ahead and raise your hand if you're able to get that link to open up so that you guys can see what I'm talking about. Okay, good. Is anybody having difficulty getting that link to come up?
Did my hand raise?
It did.
Okay.
All right. Yep. I think I saw everyone's hand raised. So this is something that I stumbled upon that through my research in into ACT and CBT and its applications in ABA. I didn't I haven't found this anywhere else looking on the BACB website, but I found an indirect link to this specific page and I thought it was really interesting. So clinical behavior analysis is like a special interest group within applied behavior analysis, and it's really focused on being able to treat stuff like anxiety and depression. And it was really kind of uplifting to me that this is on the BACB website, and this is something that they advertise, and the materials in here are really helpful. So this is something, the introduction to clinical behavior analysis, that video can be good to look at, and there's a little handout there too. So not only does this kind of reassure us that when we're talking about treating stuff like mental disorders, anxiety, stress, substance misuse, stuff like that our board and subject matter experts in our field are also doing this. So that just gives one example of how that's used. If everybody go ahead and keep that resource to review at another time. If everybody can get back to the slides, we're going to move on. So another there's two studies that I like to go over with. Each one of these we can do a whole CEU on reviewing these articles. Today I'm just gonna overview them pretty quickly. If we don't finish with enough time to meet our 2.5 CEU goal that we have today, it is appropriate to also incorporate time reviewing those articles. So either we can have those supplement our current CEU, or in the future we can arrange follow-up CEUs to review these articles. But just to kind of go over them briefly. So this first one, this is not B.F. Skinner's behavior analysis. So kind of developing more into the thought process. So it provides a comprehensive introduction to this new therapy that's rooted in functional contextualistic philosophy and a post-Skinnerian behavior analytic theory of verbal behavior. So it begins with the assertion that language or verbal processes are at the heart of psychopathology and human suffering, and goes on to describe a therapeutic approach that seems to undermine these verbal processes and facilitate clients' active commitment to value-driven behavior. Along the way, the book provides a compelling behavior analytic account of a number of important but neglected issues in behavior analysis, including human suffering, the nature and function of private events, the self. It goes over thoughts of suicide, anxiety, depression. It talks about values, responsibility, and commitment. So in doing this, the book gently challenges the common but erroneous assertion that behaviorism does not and perhaps cannot address the complexity of human condition. So this article is a review. It will provide a more in-depth overview of the book. It's going to summarize the chapters, and it's going to raise some questions that might be addressed in future research. So I found this one really interesting. It kind of pushes that bridges that gap between directly connecting ABA and acceptance and commitment therapy. Another one, I like this title, Acceptance and Commitment Therapy Training in Applied Behavior Analysis. Where have you been all my life? So this was a really fitting title to me, because I'm like, oh, thank goodness, here's an article that is specifically talking once again about ABA and ACT. So it examines behavior within context of ABA from the perspective of ACT, while understanding the role of relational framing and the transformation of stimulus function. It helps better equip behavior analysis to effectively address those complex behaviors that might be influenced by covert verbal behavior. Might lead to more comprehensive analysis of behavior and result in more effective interventions for socially significant change. Its aim is to provide behavior analysts with information and guiding on using relational frame theory and ACT training. So in this one, you'll hear a lot of people of these resources that I'm giving you talk about using ACT and ABA. This specific one, they kind of changed the terminology a little bit. Instead of calling it acceptance and commitment therapy, they call it acceptance and commitment training. So that just kind of helps it be, I suppose, more palatable, because the word therapy can imply those more mentalistic psychotherapies, whereas training implies more of the behavior analytic terms. Call it what you will. It's still ACT and it's still applicable to ABA, but that one's, like I said, a little more digestible. So it provides a rationale for considering thoughts as behaviors, and it outlines the important components of relational frame theory. And it goes over the benefits of employing ACT training in ABA. And it goes over brief descriptions and examples of using the ACT within practice. So this one will also go over some examples. It highlights the importance of expanding the consideration of maintaining variables when attempting to address maladaptive covert behavior, and ultimately aims to encourage a greater encourages more behavior analysts to adopt relational frame theory and ACT practices. So whether or not you feel comfortable using ACT, you might be really excited about it. You might still be skeptical. You might be worried about how the insurance reviewers will respond to some of it in your treatment plans. I know we have all gone through this struggle with PENs and full out denials just because we mention ACT. This article can help kind of give some backing to that. So later on, if there is interest, we can follow up with an article review for this one as well. So this is another one that I'm not going to go through too much. It's another book. I believe this one is available on Amazon. So ACT and Applied Behavior Analysis, a practical guide to ensuring better behavior outcomes using acceptance and commitment training. So this one also refers to ACT as acceptance and commitment training. So there's another resource if anyone wants to dive deeper into that. Okay, so we're going to, using some of those resources, and within the CEU, I still want to go over some specific examples on how we might be able to use these. So if we don't necessarily need to open up this link just now, feel free to open it up if you would like to look through it as we talk about it, or you can save this for a resource later. So this link is internal to OGBC. So this will go directly to a SharePoint file. It is complete worksheets for from Russ Harris. He's a big proponent of ACT in ABA, and these are going to go through. You can use the worksheets as a whole, kind of like successive treatment package when writing targets for clients. These are definitely going to be for more higher functioning older individuals. I've used this with some of my adults. So if anybody is working with high functioning adults, these might be helpful if those adults are dealing with some of these internal behavioral processes that we've been talking about. So turning these worksheets into something that can be written into a treatment plan. So once again, the biggest thing we want to focus on is observable behaviors. We want to be able to measure it. So some example targets that can be written using these specific worksheets. So a client will expressively identify a short-term behavioral goal with at least 80% correct responding across 5 consecutive sessions. So we might be asking this client to talk about their values and talk about committed action towards, let's say, living towards their value of being flexible and open to change, where they're going to show up for a certain amount of sessions. So we're going to be using that acceptance and commitment therapy processes to teach them that, but the outcome is going to be in this specific goal. So expressively identifying, that is an observable behavior term that has been widely accepted by the insurances. Whenever I use that in my treatment plans, they typically will accept that. Short-term behavioral goals, that's straight from the Vineland. So the Vineland is measuring, when we do that outcome measure assessment, they're measuring, can the individual state and follow through with short-term behavioral goals and long-term behavioral goals. So once again, that's one of the bases that we can kind of connect that to, for the insurances to be able to be comfortable with what we're working on. Another example, client will expressly identify appropriate alternative behaviors with at least 80% correct responding across 5 consecutive sessions. So maybe we're using one of these worksheets or one of these ACT principles to teach this individual cognitive diffusion through mindfulness. So if we explain to the insurance that we're going to use mindfulness to create psychological flexibility, they're not going to like that. They're going to think that we are being too mentalistic. But in the reality, we're using this as a coping strategy to encourage positive behaviors. So to expressively identify, or maybe even receptively identify, by them going through a mindfulness exercise. So we might tell our client, we're going to practice mindfulness. When you identify that you're uncomfortable in a situation, we're going to take deep breaths. We're going to focus on our breath. If our negative thoughts arise, we're going to make room for them and let them come out with our breath and let them pass. And we're going to focus on our values to get through this. We're not going to engage in experiential avoidance, and we're going to engage in this activity even though it's uncomfortable. So all of that can be easily defined in behavioral terms with some of these examples. So another kind of subcategory of ACT, or I really call it like more reframing of ACT. So acceptance and commitment therapy, they reframed it into acceptance and commitment training. Another one is AIM, which is basically using ACT, but it's specifically designed for ABA. So here's another link that can take you to this if you would rather use this model. This model can also be a little more adaptable to younger students. So this combines ABA, ACT, and mindfulness to help with daily behavior concerns and struggles one must learn to interact with on a daily basis. It's created by Mark Dixon. He's the main proponent and creator of AIM. So that's another resource to look into when you might be wanting to utilize ACT. I will say on personal experience, using the acronym ACT or AIM are good ways to automatically get something pended from the insurance. Particular reviewers even see this, and instead of pending it, something boils deep inside of them and they angrily deny it right away without even a single pend. They really don't like this. But I want to encourage everyone not to be discouraged by that, because these reviewers, they're coming from the insurance. Yes, they are focused on clinical necessity, which is important, but I wouldn't say they're experts in the ethics of applied behavior analysis. So as long as we stay true to our own ethics and making these targets observable and behavioral, observable and measurable, and focusing on generalizability and effectiveness, then we can be confident that what we're doing is ethical using these. But with that in mind, using those acronyms, we might want to just reframe it a little bit for the insurance. So, it's not being unethical, renaming it something. It's just being able to kind of divulge it in a way that's going to be more acceptable for them. So cognitive behavior therapy, there once again is a link to worksheets that focus on cognitive behavior therapy. Some people, you might enjoy both CBT and ACT. Some individuals might not like the restrictiveness of CBT with always having to reframe thoughts. There's a frame of thought that changing thoughts is not effective. You shouldn't ignore the thoughts as negative. And then those individuals might really prefer ACT, but CBT can still have a place in there. So once again, if you wanted to review those worksheets, being able to transcribe those into an observable, measurable goal can be something like clients will expressively identify various emotions with at least 80% correct responding across 5 consecutive sessions. There might be some worksheets in CBT that you would find really helpful to teach this client emotions, and then there might be worksheets to identify so situations like those erroneous thoughts of my friend ignored me in the hallway, they must hate me. That can turn into, okay, tell me what your emotion is. Tell me what you think their emotion is. So we're targeting the specific skill of expressively identifying emotions. And then we can work on alternative behaviors as well. So client will expressively identify appropriate alternative behaviors with at least 80% correct responding across 5 consecutive sessions. So that individual might, we might express that, hey, your friend didn't talk to you in the hallway, so you ignored them the rest of the session when it was time to have breaks and go play with them. What can you do instead? So we're focused on the behaviors. Instead of ignoring them, you can go up to them and say, hey, are you mad at me? And then they might respond, no, I'm not mad at you. What are you talking? Oh, in the hallway? Oh, I was so thirsty. I needed to rush and get a drink of water. So exploring those thoughts and expressly having them come up with alternative behaviors based on changing those thoughts can be something to turn these worksheets into something that's observable and measurable. Here's another workbook that we can derive treatment targets from. Goes into self-monitoring, following directions. So for example, client will track their own behaviors with at least 80% correct responding across 5 consecutive sessions. This workbook will have some worksheets for our maybe higher functioning clients where they're tracking their own behaviors and doing some self-monitoring. And then we have them report back to us on their thought processes before and after they engaged in the behavior and how we can change those to change behaviors. And then we work with them on that. And then client will follow written directions to complete a task with at least 80% correct responding across 5 consecutive sessions. So let's say you want to use one of these worksheets and you want the client to sit down, read it. Maybe they're going to write in some answers, and then you might do a role play, and then maybe you might practice the behavior that the worksheet talked about. Transcribing that into a goal is observable and measurable. Can they follow written directions? Are they going to complete a task based on our observations or a permanent product? So once again, a way that's more digestible to being written into a goal. Okay, so here's all my giant work cited for all of these. So at this point, I would like to go into a deeper discussion if we can take turns kind of talking about how we can apply these skills and any questions, and we can even go through some case reviews. Once again, if we're going to talk about specific cases, in case there's anybody external to those information for that client to follow HIPAA, let's just use either just general descriptions or initials for that client. So does anybody first want to start off with any questions, any clarifications on any of the stuff that we went over or adding on to it?
W- I mean, I guess I have a question about and I know you said the ACT, the visual that you put up.
Mm-hmm.
Um do you is there like a better place to start? Um yes, that one.
Mm-hmm.
I know they all go into each other, like you said, they all connect. But it's kind of like, how do you know where to start with a
So
client?
yeah, and that's a good idea. And the reason why it goes into all these different directions is you don't you can start at different points in the hexaflex, but ideally, you might start with the values because those kind of play into everything else. That's what we can always kind of bring it back to. So when you go through some of the resources that I provided, one of the workbooks on ACT, they list all of just like a general, I mean, a long, long list. It's definitely not the only things that people can choose as values. Those can be open-ended. But if you look at that resource, or if you even Google acceptance and commitment therapy values examples, one way I like to start with clients when I'm using this is I might give them a list. Depending on their functioning level, I might give them a short list based on how well I know them, or I might, if they're higher functioning, able to scan and look at things, then I might give them a really long list so that they can choose open-endedly. I don't necessarily limit them to like one value. They can choose multiple values, such as being loving, being present in the moment, being authentic. They might choose all of those things, and that gives us a basis to work off of the different things. So while you can really start anywhere, the values is a good way to kick it off, and have them maybe expressively identifying a value. And then in one of the workbooks as well, there's another visual that goes into the committed action, which requires the value, requires us to identify a value. So the value is in the middle, and let's say it's being kind and loving might be that person's value. That's in the middle. We pose a what's called choice point to them, where it's like a point where they got to make a choice of your parent tells you it's time to get ready for therapy and we need to leave the house, and you're engaging in a video game. So with the value being at the center, we ask them to expressly identify a behavior that would take them away from their value. So if my value is being loving and kind, and my parent tells me to stop the video games so we can go to therapy, if I throw the controller at her head, is that moving away from my value or closer? And so they want to expressively identify their behavior as moving towards that value or away. And then once we kind of want to just walk them in the direction of being able to identify for themselves that, oh no, that's not being loving and kind, so that's moving me away from my value. And then we ask them, like, okay, what is a behavior that will move you towards your value of being loving and kind in that situation? It might be, hey mom, I hear you, but like, can I please have 5 more minutes? Or it can be, thanks mom, turn the video off and go with mom, give her a hug and go to therapy, and they can identify that's moving them um towards their value. And then sometimes we might want to start with diffusion too. If the individual and it really depends on the client. Maybe the client is coming to us, they might have comorbid disorders. Maybe one of them is trauma, and they're on that particular day, or it's just from evident from the beginning of start of services, they're really, really focused on that trauma, that they went into a foster family and they weren't kind to them, and that creates maybe some cognitive fusion with the idea that they told me I'm not worth loving and no one else is going to want me, and maybe they were physically abusive, so that individual might be exhibiting a lot of inappropriate behaviors with maybe their new caregiver, of lashing out at them, yelling at them, because they're so fused with this thought that nobody will love them, so that they kind of engage in behaviors to affirm that. And so we might then want to start with focusing on diffusing them from that thought. So does that kind of answer your question?
Yeah, no, it does. Thank you.
Yeah. So yeah, I would say it really is dependent on the individual and kind of where they're coming at, and that's why it is such a fluid one. Yeah. Any other questions? Can we go into, does anybody have any general clients that they feel like they might want to work through developing one of the features that we learned towards a specific situation?
So I started some of this a little bit with my client is due.
Mm-hmm.
One of the things that we actually I had a hard time with, and this might just be a thing specific for her, but I have a really hard time getting her to get any sort of like buy-in to any of these.
Mm-hmm.
Like she would like just kind of do the things, but she was never like she never showed any sort of like she was just doing it to get through the work, I guess, like to say.
Right.
And she has a history of refusing to do any sort of like mental health therapy.
Mm-hmm.
And she's 16, so she's like at the age of like consent, so she no longer like she can actually opt out.
Yeah.
Um, so I guess like we started working on some of the values, but then I guess like what would your once we get to a point where we're ready to actually like start doing stuff in session again,
Mm-hmm.
where would your recommendation to be starting?
So that's an interesting point to be made, especially with identifying that like she's getting to that age of consent. And that kind of goes back to some of our ethics as behavior analysts. We want to make sure that there is uh compliant, not, the way that the field is going is straying away from this like rigidity towards compliance. And in our ethics, we want to make sure that the individual does have the choice. So at with any therapy that we're talking about, whether it's ACT, ABA, cognitive behavior therapy, anything, the person does need to be able to consent to it, and they can withdraw that consent. So I would say that one is not so much based in the actual components of ACT, more in the kind of shaping and pairing. So, and also kind of giving that person some choice as well. Has there been anything that they've defined as reinforcing about therapy?
We're in like a weird spot with her right now. We're like currently like completely backing everything off and we're running a like just total toleration program right now.
Mm-hmm.
Um yeah, she like really enjoys like playing games and doing stuff with us. We're in this weird spot with her right now where I think it's more her parents want her to work with us and she's refusing to because parents want her to.
Yeah.
Um so we're like kind of stuck in the middle there. So we've like completely backed off of everything, but like a lot of our successful sessions, even like before some of this started, like really did like revolve like playing games and like food
Mm-hmm.
and things like that were like pretty reinforcing. But she also does have like a pretty big history of depression. And so when she does go in those, and there's like evidence that's pretty cyclical. It's not like she doesn't have any like explicit like diagnoses, but she's being treated for something similar to bipolar.
Mm-hmm.
So when she does get those like low cycles, it's just really difficult because nothing's motivating at that point.
Yeah, yeah, absolutely. So yeah, I would consult with the prescribing physician too, because when we get into a lot of kind of like the anxiety and depression, it's helpful to, know that the medications and whatever like psychiatrists or psychologists might suggest, we want to kind of work in tandem with that. So, and being behavioral and observable, tracking those. So sometimes for clients that have difficulty with even cooperating with engaging with therapy, I will track, because sometimes your therapist or yourself, you'll go there and 15 minutes into it, they've refused, fallen asleep, to the point where you have to ethically end session and you only have like 15 minutes of an actual session. Sometimes I have a data point for, did they transition to session? Um, and then we can graph that and kind of show that, and that might help give the prescribing physician some insight on like, oh, this is effective, it's not effective, with data. And so those medication possible changes can help kind of encourage engagement with therapy. But also using kind of what you've kind of backed into, a lot of these, what I've done with some clients before, because I've had clients that are higher functioning, transitioning into adulthood, that anytime I brought up he knew what a SD sounded like. And he knew when I opened up his binder and referenced maybe a worksheet that we were going to be working off of behaviors, he absolutely shut down. Sometimes he would outright refuse. Other times he would deflect with humor or jokes or try and distract me. And when I told him like, hey, that ain't working, he would then shut down or get mad. So developing some of these into basic conversation. So with this individual, you said you've had some success with playing games. Does this individual seem to enjoy the therapist's just the their presence?
Historically, some. Right now, no.
Okay. So really kind of focusing back on that relationship can be really effective. So getting to a point where they enjoy that therapist, because that kind of goes back to some of the building blocks of applied behavior analysis, where anything that we're going to do is not going to be effective unless we kind of build those relationships. Does this individual engage in a lot of really challenging behaviors, or is it more just avoidant behaviors that they're in a depressive state and will...
Mostly avoidant, but if pushed, it turns into um, more like aggressive behaviors.
Okay. Another something else that's been effective with clients that might be, because depression is a real heavy thing, especially when they happen to get into a depressive moment with when therapy happens to be there. And maybe they're not depressed because therapy's there, but maybe they're in a depressive mood and then that happened to be during a scheduled therapy session. Sometimes I like to go over a like a homework assignment basically with them. So some of these worksheets can be printed out. You can adjust them and write your own using it as a model. And maybe you go over it during session. Maybe their responses are as minimal as saying yes or no. Or you give them choices and they choose from the choices. Or maybe you say, here's your homework assignment. We're going to work on this at a later time. And then maybe when they are feeling in a better moment, because if this individual does at times be really receptive, then maybe they can choose to do that on their own time. And then you can come back and talk about it at a different session, just to kind of match up during those times when they're kind of up and down. And then maybe your session can mainly focus on like those games. And then at the end, you remind them of the homework assignment, and then you're going to check up on it later. Maybe you come into that next session, they haven't done it. That's fine. They've at least like been given a preview of it to know what to expect. Sometimes it takes them some time to really digest it and be prepared for it. And then maybe they might be at a better space in that moment. But then also you might want to get creative and play some games that are modeled um, towards some of these contexts. So like values, you can maybe make cards like apples to apples, but like with values and committed action. And so maybe they might be a little more open to engaging in these therapies if they're in a game setting. So
Sorry,
those might be
I was agreeing with you. I just realized I was muted.
Yeah, no worries. And we can also get back together too and look through some targets and some materials to use with this too. Maybe there's already been people that adapted this into a game that I haven't quite found yet, but yeah, those might be some shaping procedures to use with this individual. But then at the end of the day, understanding that ABA, ACT, cognitive behavior therapy, none of them claim to be effective for every single person. And at the end of the day, if we've tried successive program changes, behavior modification, BIP changes, and they're still saying, no, I don't want to do this, then at the end of the day, every single therapy requires the individual to want. They have to make that first step. And so that just kind of goes back into the basics of ethics for clients, and just know that it's not a failure on the clinician or the methods themselves, because not everything's going to work for every person. All right. Does anybody else have any specific cases or are curious about how to mold something into a treatment target for a client?
I mean, I can, if I don't want to take up, if someone else does, but Theresa, you know this client.
Mhm.
And lately we've been having a lot of I hate myself, negative statements. And I know for a, because school will say, oh, he'll just explode out of nowhere. And I'm like, no, I don't think he's exploding out of nowhere. I honestly think he's thinking about something that has upset him previously. And a trigger might be someone bumped into him or, like something, and he explodes. I've done some flexibility targets with him that was suggested out of children's. But he's very also, like, he'll say it, but then when you go to like talk to him about it, he's just like, I don't want to talk about it, or I didn't say that, even though, like, he doesn't want to address it. So, and I know members of the house can make things difficult, and I've been working on that as well, but I guess how would you starting to get him to be comfortable with talking about some of this?
So I think, and I do know that specific case that you're talking about. Sometimes, just kind of going back to the parent piece, and any other individuals in the house, I sometimes like to use ACT with parent training, because the parents have so much more interaction with the kiddos than we do. We come for a couple of
Right.
hours, but that parent is with them morning, noon, and night, all times of the day. Yes, they do drop them off at school, but they pick them up, and the parent is the most, I would say, the most important component of that child's environment. And so sometimes when we identify cases like this where some of the parents' behaviors might be driving the child's behavioral choices. Sometimes I like to use ACT with them kind of as part of my parent training. So, because oftentimes we can see the parents falling into the same cognitive fusion. So the parent can be fused with their thought of, let's say they're in a store and their kid starts to throw a tantrum because they were told no about something. That parent, their value might be being a good parent, but in that moment they might be so fused with the thought of everyone thinks I'm a bad parent right now because my kid is throwing a fit in the store. Everybody is staring at me. So teaching them to, part of the acceptance is teaching them to be okay with those thoughts, and kind of living with them of everyone's looking at me. They think I'm a bad parent. Instead of doing the action of giving into that child and increasing their behaviors, we might encourage them to kind of live more towards their values, be accepting of those uncomfortable feelings, because feeling judged and having eyes on you in the store is really uncomfortable, but kind of maybe doing some mindfulness exercise with the parent of being okay in that situation. Because in this case, and in many cases, we do have parents that are going to be very open and fess up about, yeah, I have these, the reason why I give them to my kid is because I have all these uncomfortable thoughts, and it's so uncomfortable to have them go through these behaviors that I just want to get it over with. So kind of teaching them some like psychological flexibility of being okay with those uncomfortable thoughts and behaviors, to be able to follow the directions of maybe not giving in to that kid. We can still fit in some coping strategies too, which I think would be appropriate for the parent and the kid in that situation.
Right.
The field of applied behavior analysis is also moving away from a lot of extinction procedures. So instead of just telling the parent, like, wait out the behavior, there might be some of that, if they're too upset to like hear instruction. There might be still some waiting out, but we're not going to be using a full extinction procedure. But we're going to have that parent kind of be comfortable with teaching coping strategies. So let's say they go through, the parent has already learned a mindfulness technique, and that mindfulness technique has helped them be okay with the uncomfortable feelings and diffuse themselves from their thoughts and being in the present moment. So when that child is going through behaviors, they are probably got tunnel vision. They're thinking about all the other times that kid has had behaviors. Those can even happen before the kid has behaviors. So if he starts to whine, the parent knows that the whining has a derived relation to falling on the floor and throwing things. So that parent, the relational frame theory is present there too. So maybe that parent is going to get agitated really quickly when the kiddo whines. And the kiddo might be playing off of the agitation by escalating. So kind of like identifying through like some interviews with the parent of like, hey, when what are some precursor behaviors that he exhibits before he's going to go into a full-blown tantrum? And she might say, oh, his voice starts to whine. And then asking the parent to identify like, okay, what are your thoughts and feelings going through when you hear the whining? Do you start to think about all the other times that that's gone into a full-blown behavior? How does your behavior change in the moment that he starts whining, and how might that attribute to it? And then, hopefully we are able to walk them in the direction of being like, oh, wow, you're right. I do get really stern with him when he hears the whining, and he does get escalated, and then I get more escalated, and then I end up just taking him out of the store and abandoning my shopping trip, or I just end up buying it for him. When they're kind of open to that process, we're able to kind of teach them like, okay, first you're going to use a coping strategy. You're going to take these deep breaths, or maybe you're going to look around and identify 3 things that you see, 3 things that you smell. You're going to let negative thoughts come up and you're going to let them go. And then you're going to teach the kiddo to do the same thing. So the ACT can kind of be used first at that parent training level and then through to him. But then also, the reframing, that might be some CBT, reframing behaviors and thoughts might not be super effective for him. It might be better, because that particular kiddo I know, and some other kiddos might be the same, where they feel that their emotions are wrong. So like an emotion of anger at being told that the class has to stay in for recess, the whole class. Though that can arise. And if the kiddo is maybe has this inflexibility or this erroneous thinking error that it's not okay to feel angry, that's going to expand. So maybe also explaining to kiddo that in other contexts, like, hey, I get angry when my flight is delayed. I get angry when the store is closed when they're supposed to be open and I can't get what I want. Those feelings they're okay. I can be okay with feeling angry, but then I need to kind of just think about which direction I want to go. Do I want to go towards my values or do I want to go away from my values? So maybe kind of some acceptance would be a good place to focus for him, instead of being so distraught over the fact that he's having emotions that he just doubles down and completely blows up. So probably acceptance and then diffusion in the form of coping skills. And then even like reinforcing those during session too, of instead of maybe doing an extinction procedure, maybe he's when those precursor behaviors show up, he's doing some breathing exercises or, something else that he's maybe during a neutral time, you've practiced a lot of different ones and he picks out his favorite.
Yeah.
So reinforcing those behaviors as well.
So with him, sometimes if he does do, like, let's say he does do like a calm down or a coping strategy, if I point it out even after he's done, he'll get defensive and re-escalate. So bringing it up at a different time, does that make sense, instead of immediately?
Yeah. I mean, if you find that it's successful to bring it up at a more neutral time, then that's good, or not at all. Even because he could be reinforced just by moving on.
Yeah.
Yeah.
I would say
So,
that's mostly, yeah.
Yeah, and then being able to identify the things that re-escalate is important too. So being able to have that knowledge of through trial and error of, praising him or pointing it out re-escalates him. That's an important thing to know because we're talking about ACT within the context of ABA, so it has to fit in to our knowledge of what's reinforcing and what's punishing, and being able to manipulate those things. So yeah, not talking about it at all, and the reinforcing stimuli might just be moving on.
Yeah.
Is I think it is totally fine, a good way to mold ACT into our ABA principles.
Okay.
Yeah, I think that's a really good example, and I think there's definitely some exploring we can do with ACT for him. Maybe AIM, looking into more of those AIM activities, because those are geared towards
the younger,
some younger kiddos. And I know he really likes games too, so
yeah,
there can be some ways that we can, because it's funny just knowing him specifically. He tolerates losing in a game pretty well. It's tolerating no and losing in other situations that are hard. So even taking that neutral activity where he doesn't have a problem and reframing the game into that, it can give him more exposure to the ACT. And so let's say we point out like, hey, you lost at the game, but like you were okay with it. That's like we're showing some flexibility, and you're living towards your values. So that differential reinforcement of finding the positives, and reinforcing that can hopefully generalize to when he's upset. He's not going to be as apt to accept us redirecting him, but maybe just that practice will help him. But of course, that's something to keep an eye out for, to see if he starts exhibiting maladaptive responses to that previously neutral experience. But definitely something to try out.
Okay.
I'm really glad you brought that up, because I actually have a new kiddo who has a really big aversion to negative feelings. And I did not think about using this with him. So that's a good idea.
Yeah, and like I said, AIM for younger kiddos it has been more adaptable in those situations. But I mean, we can break down these components into much simpler pieces to use within ABA. And yeah, I think even just the talking about the history of AIM and relational frame theory, opening us up as behavior analysts to the understanding that thoughts do have an effect on our behaviors, and uncomfortability with those thoughts too. Kids on the spectrum, they tend to overgeneralize things. So somebody in their past might have unintentionally taught them that being mad is not okay. That you should be happy when you lose a game, that you should say okay and skip off into the sunset when your parent tells you that you can't have ice cream. Like, in those situations, we're completely ignoring the natural thought process that we go through with humans. And so sometimes when we teach kids those responses, they get this incongruence with the actual emotion that shows up. So if they're taught, I should never be angry when my mom says no, then they feel angry and they're like, oh, I'm doing this wrong. And then they get more angry. But if we teach them, if we're more specific about our teaching, with specifically saying, if your mom says no, you might feel angry. You might think X, Y, and Z. And we can even go through thoughts of, you might think she's the meanest mom in the world. Going back to cognitive behavior therapy, where we're maybe reframing thoughts can be effective. She's the meanest mom in the world. Okay, well, that's a natural thought to have, possibly. And the emotion of anger is a natural response to have. But let's think of some more maybe realistic thoughts. Maybe your mom said no to that ice cream because you would have had a tummy ache if you had ice cream for dinner before eating your meal. And then, like, let's think about how that might change our emotion, or if we're looking to act of like feeling okay with that anger, but then our behaviors need to be moving towards having committed action towards moving with our values of being kind and loving, and not exploring those can really have us miss out on a lot of those internal processes that affect behaviors.
Yeah.
So yeah.
That makes sense, because even mom of this client has said that the culture that she was raised with and that this child's father was raised with is, you don't talk about emotions. So she knows, and she realizes that is not, she does not want her son to be raised like that. So
yeah, so changing values too, like identifying values that you were raised with that maybe are not the direction that you want to go into also, and those are things that maybe the parent moved on from, that they probably didn't enjoy their upbringing, but then they're subconsciously having some of those thoughts and values relate onto kiddo, and then that's built kind of going back to those core beliefs when talking about CBT. Their core beliefs have been developed into you don't talk about emotions, mad is wrong, you talk back, you get hit, sort of old world thing. That's ingrained into a core value. And so not only is that that can be ingrained to a core value of a neurotypical person and that creates a possible mental disorder in a neurotypical person, but then think about the effect on that of a child who's neurodiverse with autism, who is extremely rule governed and rigid. They are going to do that times 10. So while that gives us an understanding of where they're coming from, we want everybody involved in that caretaking for that kid to kind of understand those processes, but then also move on from there. Okay, we've kind of developed an understanding of where this came about, and sometimes there's some comfort in knowing that this child's behavior just didn't come out of nowhere, because that means we can change it, and knowing that it's going to be kind of a little bit of an uphill battle. We might take one step back and two step forward, but being okay, and then the coping with it too, of not giving up and moving towards those values, even if they take some discomfort with moving towards, because sometimes parents can do really good and then they can slide back, and then we need to kind of like realign them to that. So yeah, teaching the caregivers to kind of know this stuff too, and use it with themselves, is going to be more effective in them being able to buy into teaching it.
Awesome. Okay. And AIM can be used maybe also for, I have a client that was just diagnosed with the intellectual disability. So can that kind of be used as well for that?
Yeah, it definitely depends
Like
on their,
adapted, I guess.
yeah, I think
Okay.
all of this can be adaptive and shaped into, you know, some a little bit for everybody. You know, we might not go, you know, their intellectual ability might limit how deep we can go into it, but there's still some pieces of this, by looking through some of the components in the different workbooks that we have in the resources, can be kind of whittled down into something that can help with individuals with intellectual delays as well. So we have a few more minutes for discussion before we can go ahead and for the day. Does anybody else have any final case reviews, any final thoughts or questions? So going back through, I'm going to send everybody the slides with the links that you can access to kind of help with being able to turn some of these into some stuff that we could put into treatment planning. If the articles in the books are more so to kind of delve into more of an understanding of these principles, but feel free to look into those, reach out if anyone has any questions. Reach out to me if you would like to do another, maybe shorter CEU on a specific article that might kind of help us go deeper into this. And then feel free to check out the references, because a lot of these references can get us towards some resources as well. Some of these can be cited when we're doing those insurance pens. So if they pick something back and they want raise your hand.
Yeah, I did have a question about that because I can't read them fast enough. When I've talked to the insurance people, they've always asked if they were in Java. and I didn't know if you've had success with articles that were not in Java.
Honestly, even if I give them a Java, they end up not accepting it anyway. I've
Okay.
honestly, yeah. So not saying that, because it is something they ask for and something that, you know, we do want to go with, but it's interesting that oftentimes, even if I find something from Java and give them a resource, they find a way to discredit it anyway, and I end up just rephrasing
Okay.
my targets, and that works. But one interesting one, so that BACB website where
Yes.
so if that one came to mind specifically when some of these reviewers might tell us, hey, you're not acting within your scope of practice, you can be like, hey, well, you can educate yourself. This is from our board who controls our ethics, and is the guiding force behind us acting within our scope of practice. Like, you can watch this 45-minute video on clinical behavior analysis and see that is within our scope and is medically necessary service under ABA if you want to fight.
Okay.
Honestly, coming back to them with resources is, if you are in a mood to fight, if you just want your treatment plan approved, honestly, rewording and restructuring your treatment targets is the way to go. So kind of thinking about taking those targets that you really want to work on and expressing it in behavioral and observable ways, just rewording it often is the easier way to go. You still get to feel ethical with providing your client with something that you feel is effective. And then you get to feel ethical with knowing that the research that you've done behind it, and the way that you're measuring it is behavioral measurable within your scope of practice. And that it's getting approved by the insurance just because we reword it. So those are two different ways to go when we butt heads with the reviewers. It's all fun. Okay, guys, so I'll let you go on with the rest of your day. I'm going to be sending these out this afternoon. I'll send out the slides. There is also going to be a short quiz that I would like you guys to answer back on. So that'll be available for those that were present during this, but also for people that are listening to this recording afterwards. And then once you email me back with some answers to the quiz questions and a review of the CEU, I will fill out your certificates for CEU credits. We're going to be doing 2.5 on this, so please let me know if time is of the essence. If anyone's needing to submit these last ones for recertification, I'll make sure to get them out quicker. But I hope the turnaround is only will be about 24 to 48 hours for everybody. So yeah. Thank you everybody for coming, and I hope you guys have a wonderful rest of your day.
Thank you.
Thanks, guys.
Thank you.